Good evening and welcome everybody from New Canaan Library. I'm Anthony Maricola, Manager of Adult Services and Programming, and I hope everybody is doing well. We have a great program for you this evening. Tonight we have Dr. Helen Pass with us. Dr. Pass, who is certified by the American Board of Surgery, limits her practice to surgical diseases of the breast. Dr. Pass is co-director of the Women's Breast Center and Chief of Breast Surgery at Stamford Health. Formerly served as Director of Breast Services at New York Presbyterian Lawrence Hospital at Bronxville, as well as the Chief of the Comprehensive Breast Care Centers at William Beaumont Hospital. On a personal note, she is a wife and a proud mother of twins and 2 four-legged children. Tonight, she will be speaking on the topic of breast health. Dr. Pass, we are so happy to have you with us this evening. The virtual floor is all yours.
Perfect, thank you. I'm not the most tech savvy, I will admit, and my daughter's not here to do it for me, so just a little patience, please. Okay, I think we're almost there. Perfect. So again, it's my great pleasure to be able to talk to all of you guys, and hopefully I will take you through a nice lighthearted romp through this. Just trying to minimize. A little talking head picture. There we go. Perfect. So I lightheartedly called this Everything You Wanted to Know, but Were Afraid to Ask, because there's so many myths, so much misconception, and so much apprehension around our breasts that I really wanted to go through a variety of topics. I always laugh. People tell me I talk really fast. I will try to slow it down. We're going to go through a whole bunch of different topics and hopefully learn something as we go. I really have to take away everybody's myth that the breast is a giant sexual organ. Actually, it's just a sweat gland. It differentiated a little bit differently than your other sweat glands, so it produces milk instead of sweat. But it really is a big modified sweat gland. Not very exciting. The proof is in the pictures. I'm always somebody that says, well, you tell me that, but it can't be. So if you look at this little diagram, there's a duct and then there's a gland. And so if you look at a breast gland, there's a nice little duct and then there are our glands. So you don't have to believe me, proof is in the pictures. And that's what we have. Breasts are very complicated. There's actually your skin envelope, then a layer of fat. This layer of fat is why your breasts gain and lose weight when you gain and lose weight. And it's really depressing when you work really hard to lose weight and you lose it in your breast and not your stomach. I'm really sorry, I don't have an answer on how to avoid that, but that's why they seem to fluctuate in size. Like every part of the body, there are blood vessels, veins, and arteries. They're all your milk ducts coming right out of your nipple papilla. And those, get this little guy out of the way even more. Those actually terminate at the end of your nipple papilla. And then each one of these ducts end up terminating in these milk glands that are scattered throughout the breast. And your breast tissue goes up actually just below your collarbone, all the way to your breastbone in the center, slightly below that fold where your bra hits, and then all the way around sort of to where if you were wearing an underwire bra, that underwire would hit you on the side. Everything past that underwire is just your back fat. And so that's part of where when we do our breast self-exam and when they do mammograms, and why when they do mammograms, they pull so hard, they're trying to make sure they get every piece of breast tissue and actually see this pec muscle back there. So if the radiologist is looking at your mammogram and they don't see this muscle, they're also afraid they might not have seen something hiding in the back part of your breast. And that's why the technician seems like they're really pulling your breast out. The fancy name for this brown part is your areola, and the fancy name for the part that sticks out is the papilla. My daughter always said you have to have big fancy words for everything, and I'm like, yep, that's why I went to medical school. But breasts are normally lumpy bumpy. You're feeling these glands surrounded by normal supporting tissue with these ducts that run up and down, and there are even supporting ligaments that go up and down this way that you can sometimes feel. They're a very busy organ in the body. Breasts come in a whole variety of sizes and shapes. We have in our minds somehow what an A cup is. In Europe, they don't go D, double D, triple D. They go D, E, F, G, H. And yes, breasts come in H and J sizes as well. Every size is normal. You can't predict. You can be a very slight frame and end up with great big breasts. You can be more heavily framed and still have small breasts. It doesn't necessarily correlate with your body size. It does somewhat run in families. Some families tend to be bigger breasted than others. And you really can't predict what size your breasts are going to end up until you're 19 or 20 years of age. Pre-puberty, you have a lot of ducts, very few glands. And when puberty happens, you start forming these little bright red stuff are your milk glands. Once puberty is over, then you've made all the breast glands you're going to, but they haven't really fulfilled their final destiny. It's only with pregnancy that comes to term or near term that these glands then learn how to make milk and finally can produce milk, but also finally get their final differentiation or actually become everything they're going to be. Some people have heard and other people don't know that never having kids is a risk factor for breast cancer. And that's because your breasts have been stuck in this state where these cells still want to finish dividing and developing. And so they've got this potential. And if they've got this potential to divide and develop, they can also do it in the wrong way and turn into cancer. And so whether or not you breastfeed, just the fact that you've had a full-term pregnancy and the breasts have gone to this final development or differentiation is somewhat protective for breast cancer, but only if your full-term pregnancy was younger than the age of 30. It's a risk factor. I tell people it's a risk factor we can't do anything about. I don't go around advocating early childbearing just to decrease your risk of breast cancer. We've got other things we can do. But like anything, way back when, it used to be called the nun's disease because nuns didn't have children, and people realized that nuns had an increased risk of breast cancer. And then some smart scientists really figured out the connection between why women who have never had children have an increased risk of breast cancer. As we talked about, your breast size varies with weight, and it can be dramatic. They can actually see it on your mammogram. So they can see when you go up and down in breast size because that's basically a fancy picture. You will, as I said, notice it in your sizing of your bras. And again, I have no magic answer to say, how do you lose the belly fat and keep the breast fat? I know a lot of women did. Now, people also think, wow, I got my bra professionally fitted, 4 years ago, I'm just going to keep ordering the same size. Well, it's estimated that at least half of women, and there are probably even estimates higher than that, are in the wrong size bra. And the average woman's breast changes shape and size at least 6 times in her life. It changes after you complete puberty. It'll change if you become pregnant. It'll change after you stopped breastfeeding. I think any woman who has done that can clearly look at their breasts and go, yep, they're not like they were. And then it changes when you become postmenopausal, and it also changes with weight gain. All of these changes are normal. All of these changes are not concerning to us, especially if it's happening in both sides and it seems symmetric and you've got a great, like, oh, I worked really hard and I've just lost 30 pounds. And you look down and your breasts seem a little more deflated, you've got the answer. Same thing like, oh, the holidays were really good. I put on 15 pounds, but now my bra is not fitting quite right. Again, stop, think, did I get a bigger pair of pants? Maybe I need to get a bigger bra. It's amazing to me because bras stretch. How many people are like, yeah, I went up a pant or 2 sizes, and they come in saying I've got breast pain and the marks from their bra are just digging into their skin. I'm like, you got bigger pants. Did you get a bigger bra? Now, unfortunately, exercises do not change breast size. Way back in the 40s and 50s, they marketed all these devices. They, like the Mark Eden Best developer, if I just squeeze my pecs, it's going to make my breast bigger. Well, your pecs are the muscle that's beneath your breast, and you can't plump that muscle up enough to really make a difference in breast size. They had machines that would go on almost like a breast pump, and we're supposed to like draw the breast out. Yeah, it may give you a little swelling temporarily, but nothing permanent. I love this because you Google and you can find anything. They're like, look at all these exercises that will firm and lift your breast. No, push-ups, pec deck, Triceps, biceps, build those muscles. The breast is not a muscle. You cannot build it up. Same thing. You can't reduce your breast size either unless you lose weight. Same thing. I like this one. We're going to take you from flat to perky. I really wish it was true, but it doesn't really happen that way. People seem to think, well, if I've got teeny weeny breast, I'm not going to get breast cancer. And the answer is no. I wish cancer was that smart that it said, well, you know what? Every woman could get a breast reduction and then they would drop their risk of breast cancer in half. Small breasted women, the incidence of breast cancer is exactly the same as large breasted women. It has to do with our sensitivity to things we haven't even discovered yet, as well as our exposure history, as well as our genetic makeup. And as I said, a large part due to things we haven't discovered yet. Your biggest risk factor for getting breast cancer, if you are a female listening to this, is being an American female. 1 in 8 American females will get breast cancer. And I honestly just saw a paper that said it's going down to 1 in 7. In the 60s, it was 1 in 20. When I was in med school, the correct answer was 1 in 12. And honestly, it wasn't that long ago. We've said 1 in 8, and I just saw my first report that said 1 in 7. Again, I wish we knew why we had such a rising incidence of breast cancer. It's not just better screening. We've had mammographies around since the 70s. So it's not like, oh, we're finding cancers that aren't important. With all due respect to the esteemed medical journal, the New York Times, and I say that sarcastically in case it didn't come across on the web, there is such a thing as overdiagnosis, but it's not as full blown as some of those editorials would make you believe. Again, screening finds cancers at a smaller size. Finding cancers at a smaller size means they're more treatable and you have more options. So again, thinking I'm protected from breast cancer because I have small breasts and I'll never get it is not the right way to think. Also, women come in and they go, you know what? One breast is bigger than the other. It can be distressing. It can be difficult to get dressed. They make all sorts of little slang term cutlets, but little push-up pads to go into your bras to make things symmetric. I tell people, just like, you know, one foot's bigger than the other when you go buy shoes, like I have to try on the left shoe first, because if it doesn't fit the left foot, it's not going to fit the right. It's not unusual for breast sizes to be up to a cup, but not infrequently a half a cup size different. And so again, for some artists, they actually believed asymmetry was beautiful. And that's why if you look at a lot of the classics and you try to fold their pictures on top of them, they don't perfectly match up because asymmetry is more beautiful to the eye than true symmetry. So I'll tell my patients, breasts are like snowflakes. No two are alike. You can look at your mom, but you won't necessarily be shaped like your mom. If you've ever been in a locker room with a bunch of women changing, you'll see all sorts of them. I actually ended up at a nude beach over Christmas. Too much information, but I was surprised. And let me tell you, no two are alike, and I do this for a living. As I said, it's very common to have different sizes in your breasts. This little graphic said 97% have different sizes. It's usually not as profound as the cartoon makes it out to be, but in 50% of the people. And if one breast has always been bigger than the other breast, that's nothing to worry about. That's nothing unusual. That's nothing worrisome. If all of a sudden you've always known how your bra fits and now one breast is all of a sudden shrinking or growing in that size, then yeah, that's time to go see your doctor and get more evaluation. Many odd findings are normal. I love this slide because I've had people come in and ask about all of these. So this is a far picture and this is a near picture. These little bumps right on your areola are called Montgomery tubercles. Yes, we have to have fancy names for everything. These are oil-producing glands that when you're breastfeeding are supposed to protect the skin, keep it lubricated to prevent the cracks and fissures that come along with breastfeeding. They can, just like other little glands, get bigger or smaller with time. Every once in a while, the little opening can get clogged and they can get really big and they can even get infected. But it's very normal to have these little bumps, and they usually end just beyond where the color changes. And they can, as you can see in this picture, look pretty profound. So that's very normal. It's also very normal, like if you look at this nipple tip, which we call the papilla, and you see this little line in here and then a second one, she doesn't have two nipples. She has a little clefting of her nipple. More common in smokers because smoking causes buildup of waxy material in your nipple ducts and can increase your risk of getting infections in there. But this clefted nipple, especially if it's how you've always been, is normal. It also tends to be very normal in smokers, and as long as it's not progressive, we don't worry about it. Breasts are also like belly buttons. Some are innies, some are outies. Outies are more common than innies. If your nipple has always been an innie, then it's not a worrisome finding. If your nipple was an outie and became an innie, then we're worried about it. Time to see your doctor, usually time to start imaging, because some cancers can cause an outie nipple to become an innie nipple by pulling on it. And despite what people think out there, you can breastfeed with an inverted nipple. They make nipple shields to help you be able to help your child latch on. Breastfeeding is not intuitive or easy anyways, so it's one more hurdle, but it's not an impossibility. These hairs are normal also. So these hairs that go right around your areolar complex are perfectly normal. Some people hate them in tweeze, other people, they don't bother, but it's not, you're not getting hairy. It's not a sign of a hormone imbalance. It is what they are. If you're going to tweeze them, it's like any other part. Use clean instruments. Make sure you use an antiseptic. I have seen a rare infection when people tweeze and get in hot tubs that have had bugs in it or otherwise get exposed to bacteria. This is also another normal variant. So we call this accessory breast tissue. I have a little picture of a dog because if you'll notice, a dog has multiple nipples. They start at the level of her armpit or her axilla, and they actually go all the way down in a little line to your groin. And you can find these nipples extending anywhere. So here's somebody who's just got the nipple. Here's somebody who just developed the accessory breast. And you can actually have an accessory breast with an accessory nipple as well. In some cultures, an accessory nipple is viewed as a sign of virility. Other people think they're just a strange mole and don't really recognize them for what they are. They're not dangerous. They're just cosmetically, some people don't like them. Usually you do not have accessory breasts tracking down. The most common place we see those are in the armpit or the axilla. It becomes important for two reasons. For women who get pregnant and go on to breastfeed, this can get engorged and it can be difficult sometimes to get the milk out of there because there's no duct leading out the nipple. And so it can get quite stretched with pregnancy and be uncomfortable, and you really have to work on expressing the milk out of there. And the other thing is, if you have these, you want to make sure that it's breast tissue, it's encompassed when you do check yourself. And I'll take an aside and say the American Cancer Society no longer recommends monthly self-breast exams. I tell people I don't discourage women from doing them. Everybody's got these, they're free, they're accessible. But you're not a bad person if you don't mark your calendar the first of every month and go, I laid in bed and did a 30-minute breast exam. No, being breast aware is what we talk about. So when you're in the shower, check when you're all wet and things are slippery, rub your hand. Don't squeeze your breast like you're making a sandwich or holding a sandwich. That tends to compress and you'll feel the underside of your finger and many weird things. Just rub your hand like you're putting on soap or lotion against your chest wall and you will feel it. So if you have these, you want to make sure you check that area. And also with imaging, that's why, again, the mammography technologist will really try and push that machine up into your armpit. So I always tell people they're positioning so that they don't miss any breast tissue and they squeeze because they care. Okay, so lots and lots and lots of myths out there. One of them is that the bra is bad for your health, that underwires cause cancer. And there have been many, many studies that have really come out and been able to prove that bra wearing is not associated with breast cancer risk. So no, wear a bra, not wear a bra for comfort, but underwires, tight bras, loose bras, not wearing a bra has nothing to do with it. The second myth that is out there is that antiperspirants and deodorants cause breast cancer. He's here to remind me, not because he's good to look at, but one of the myths are that deodorants cause breast cancer in women because we shave our armpits, then we put deodorant on, and the deodorant has access through the skin to go on and cause harm. Well, a couple of things. If it's going through the skin, it's not going to the breast, it's going from head to toe, so it's not doing harm to your breast. I will say as an aside, there are some studies that have shown the aluminum and antiperspirants may be linked to Alzheimer's, like all those equivocal terms, maybe, not definitely. So it's not that we shave, we put on deodorant, and that's why women get breast cancer. It's not that men put deodorant over hair and they don't get breast cancer. And this little cutie here is to help me explain true, and not related. Women have a much higher incidence of breast cancer than men, 1 in 8 or 1 in 7. And it's less than 1 in 100 men get breast cancer. Men don't usually wear bras, women do. So, oh, bras cause breast cancer? No, women wear bras, women get breast cancer, but the bra's not causing breast cancer. And so my statistics professor taught me it this way. Excuse the way I have to explain it, but he's like, obviously toilet paper causes hemorrhoids because I've never known a hemorrhoid sufferer who didn't use toilet paper. So two common things, but one does not cause the other. So bras don't cause breast cancer. Antiperspirants and deodorants don't cause breast cancer. Now, interestingly enough, I didn't know that bra myths varied by countries. In the US, we all have lots of blogs saying bras cause cancer. And in France, the bras cause sagging because your breasts aren't exercising and they're depending on the support from the bra, so they lose their natural built-in support. That's not true either. There are some people from puberty on have breasts that are more ptotic, is the polite term for droopy. There are other people that still have perky breasts later in life, and it has nothing to do with how you support them. Also, people are like, well, if you sleep on your stomach, that's going to flatten your breast. If you sleep on your side, they're going to roll to the outside. If you wear a bra to sleep in, you can prevent sagging. Well, a couple of things. Sleeping in a bra is not bad for your breast. It doesn't cause cancer. We've already said bras don't cause cancer. Sleeping in a bra is not going to prevent cancer. It's not going to prevent sagging, and it's not going to prevent flattening. A bra is there for comfort. It's there for cosmetic reasons as well, but part of it is to provide support and comfort. So some women like to sleep in a bra. They feel much better. They feel cooler. Other people can't stand the thought and take their bra off when they get home. Anything you want, it's all good. So again, 3/4 of us wear the wrong size bra. You're supposed to measure just underneath your bra, right where that white line is, and that's your band size. Then you're supposed to measure wearing a supportive garment, not when they're flat and sagging, excuse my impoliteness. And then the difference in inches is your cup size. Finding somebody who can fit your bra appropriately is an art form and difficult. There are actual fitters in Nordstrom's who will come in and look at it and say, no, it's pulling away here. Let me get you a different size. There are places that specialize in post-surgical bras, and they have certified fitters. But again, it's amazing when you go get fitted and you're like, huh, I was always wearing that and I should wear this. And you then try it out and you're like, okay, it's more comfortable. So it is amazing. But again, getting properly fitted every once in a while just to point you in the right direction rather than by trial and error can be beneficial, especially if you're noticing shoulder pain, back pain. You can't wait to take your bra off at the end of the day because it just feels too tight. Now, why do we wear a bra when we exercise? Part of it is for modesty, I will say. Part of it is for comfort. If your breasts are moving up and down while you exercise, it's going to hurt eventually. So even an A cup breast move 3 inches with exercise. That's a lot of up and down, up and down. They've made a whole field of bras and low impact and high impact and pretty colors and ones that are meant to be shown and ones you still wear outside. The bottom line is finding one that is comfortable and preferably one that wicks sweat so that you don't get that annoying rash underneath your breast, which tip, if you get it in the summer, if you get it after you exercise, because you're always moist, and you get a fine little red stippled rash, that's usually an early fungal infection. So you want to keep the area clean. You want to keep it dry. It's amazing, again, when you go Googling breasts on Amazon, what you find, but they actually make bra liners that are absorbent, can be made out of bamboo even. They make one that looks like a panty liner that you tape to your bra and you can remove after it's catch the sweat. And a lot of over-the-counter antifungal powders work really well for these mild breast red rashes that are helpful. And so you can sometimes try an over-the-counter therapy before you go seek medical care. I tell people avoid the shoals, avoid the Gold Bond. They don't really have the active antifungal. You want the Mycotin, the Tinactin, the one that on the bottle has the really long name, ketoconazole, or they make another one as well. And I tell people, if you get the spray powder, not the spray liquid, you can hold up your breast, spray it underneath your breast, repeat for the other side. You've got a nice even coat of powder, hasn't fallen all over your floor. The spray liquid keeps the area wet, so you don't want it. If you like powder better, they make athlete's foot powder, and they even make a powder that's in a container with an angled nozzle, like your toilet bowl cleaner comes in for people with jock itch, because it gets into the crevice well. That works well for breast as well. So again, everything you always wanted to know about your breast, but were afraid to ask. So hopefully by now I've got you well into your glass of wine. Your family history is a risk factor for breast cancer, but you can't pick your family and you can't change it, but you should know about it. So you should know what's gone on in your family on both your mother's and your father's side. We care about both sides. Breast cancer can come through the dad, because even men who carry a bad gene for breast cancer, the deleterious gene for breast cancer, can carry the gene. Their incidence of breast cancer, even if they have the BRCA gene, is much less than women who carry the BRCA gene. So it can hide in family trees if it's going down the male side, and especially if there aren't many female relevant relatives. Sorry, my dog was barking in the background. Thanksgiving is actual National Get to Know Your Family History Day. I found that sort of funny, because they're like, well, everybody's around the table. It's a great time to catch up on, did you know what great Aunt Tilly died of? Or, oh, did you know cousin Susie developed colon cancer? I had one person who said, oh, at our family, it's always National Healthcare Proxy Day and Healthcare Declarative Day. So we all know what everybody wants in case of an emergency. But it pays to know your family history, pays to know both sides. And the bigger your family history is, the more you know. People with really small family histories, people who are adopted who don't know their family history, are just missing a piece of information. It's not like, oh, whoa, I can't do anything. This is a big, important talking part on this slide, even though it's a pretty little graphic. People incorrectly believe there's no history of breast cancer in my family, so I won't get breast cancer. Most women develop breast cancer without a family history. 10% of breast cancers are hereditary. 25 are familial, meaning we haven't necessarily found the gene or other risk factors, and 65% are just bad luck. But only 10% of women will have a positive family history. So if you've been sitting there going, I don't have to worry, I eat healthy, there's no cancer in my family, that's not a free pass. Also, people have been very interested in doing the direct-to-consumer testing. I got very interested in 23andMe, and I went and I read the whole list of genes they test for, because I was curious, because they're like, we'll tell you if you're at risk for gallstones. Nope, only if you have this one specific gene that's very common in Native Americans in southwestern US. Okay, I don't think that's many of us. Otherwise, it's like, it doesn't really apply. 23andMe tests for 3 genes that are very prevalent in the Ashkenazi population who have BRCA mutations, and that's it. Our gene panels now stretch to over 72 genes. And so maybe if you're Ashkenazi, it would be a starting point. But if you're not of that Jewish heritage and you're like, yeah, and I even did 23andMe, I don't have the breast cancer gene, it's not complete and it's not enough information. Lifestyle matters. So 85% of all breast cancers are caused by factors, some which we don't know, environmental toxins. We do think that One of the reasons the rate of breast cancer has increased since the 60s is probably because there's a lot more pollution in our environment. There's a lot more hormones being used in our livestock. You can get a cow to market in 1 year if you feed it growth hormone. It takes 3 years if you don't. And if you give that cow growth hormone, it then pees in the grass that runs off into our rivers that then gets us exposed. So environmental toxins that you don't even know you're being exposed to are out there. Bad eating habits. There's no specific breast cancer healthy diet. Our nutritionist will tell you if it's good for your general health, it's good for your breasts. Mixing up lots of different colors. Your plate should be a bounty of color. Everybody's always heard, well, eat 5 fruits and vegetables a day. That's great, but try to get in at least 3 colors. And also remember the current size of a lot of our fruits. Like you go buy an apple and it's big. I mean, a serving of an apple is like this. So before you tell me there's no way I can eat 5 fruits, they're not telling you to eat 5 fruits. They're telling you to eat 5 servings. And you'd be amazed when you look it up how different a serving size is. I always like this too, stress. Oh, well, so don't be stressed. So now I'm stressed about having stress. Well, it's one of those saying, be aware of your stressors, and if you can moderate them, do. One of the great things for decreasing stress is exercise. Exercise can decrease your breast cancer risk by 25%. So that is really great. And they don't mean running a marathon. Walking 3 hours a week. That's a half hour a day with 1 day off for bad weather. Or if you took 2 days off, then do 45 minutes the next 2 days. That can be pushing a stroller. That can be walking your dog. That can be walking around the track at school while your kids are doing their sports activities, or walking around to school while they're in there for their after school activities. So don't feel like, oh, I have to go break a sweater, it's not worth it. My daughter and I now have a saying that says some is better than none. And even if you only get in 20 minutes is better than 0. Also, we know exercise is a great reliever of stress, and people who exercise routinely sleep better. And so all of those are great modifiers. Why we want to eat well also is fat stores estrogen. Fat also converts the small amount of estrogens your adrenal glands make. And so even after puberty, even after menopause, you are still making estrogen, because people are like, well, I'm postmenopausal. Where's this estrogen coming from? Well, your adrenal glands send out hormones that your fat then converts to estrogen. That's why women who are overweight have an elevated risk of breast cancer and an elevated risk of uterine or endometrial cancer, because that's another hormone sensitive tumor. So again, obesity is really set to become one of the leading causes of breast cancer and also many other cancers. Now, if I've already put you on your second drink, stop there tonight. Don't have a third. I know you're not driving anywhere, but women who drink 2 to 3 alcoholic beverages a day have a 20% higher risk for breast cancer. A lot of you may know Dr. Takayatsu. Katie's great. Katie always says, try to keep it to 4 drinks a week. And a glass of wine is not like this. Remember, a glass of wine is like that. So you can't take 1 bottle poured in 1 really large glass that I once saw for sale at Bed Bath & Beyond and say, I'm only having 1 glass. So know your glass sizes. But again, try to keep it down to 2 a day, maybe 4 a week. And you shouldn't stack them all up on the same day, because binging is bad as well. So I'm sorry to be the no fun police also. I really wanted to go through some mammogram myths, because there's still barriers that patients face getting mammograms, and some of them are psychological. At the end of the talk, Barb Carr is going to come on and help you get through some of the logistical issues with getting a mammogram. But the first myth is, well, you're going to get cancer anyway, so mammograms don't help. It's true. They don't prevent breast cancer. The goal is to find cancer. Women always go, how could I have gotten breast cancer? I got my mammogram every year. And I'm like, that was great, because now we found it small and early. So yep, mammograms do not help prevent cancer, but they definitely help us find breast cancer early. And 3, maybe even 5 years with our newer 3D mammograms before they can be felt. People are like, yes, but mammograms have radiation and they can cause cancer, because radiation can cause cancer. To be very specific, mammograms use such a small dose of radiation that it's the same as flying on a plane from New York to California. And I've never heard somebody say, I'm not going on vacation because I don't want to get on a plane and get exposed to radiation. The amount of radiation in a mammogram is the same as the ionizing radiation you get at living at elevation, say living in Denver. And we don't tell people Denver's a no-go zone. So it's a convenient excuse. And people go, well, it's fine if they'd only take 2 pictures. But last time I was there, they thought they saw something. They took 6 pictures. So now I'm going to wait a couple of years so that it averages out. And the answer is no, especially if you needed more pictures. We want to see you back when we tell you to see you back, to make sure that something we were worried about really isn't something but was so small we couldn't see. And again, I will point to the fact that I have many people who fly New York to California monthly. So getting a couple extra mammogram pictures is not a good excuse. Mammograms are inaccurate. I get mammograms, they never find anything. They only see things on my ultrasound. So why am I even bothering to get a mammogram? They're imperfect, true. It says right on the bottom of a mammogram, mammograms can miss 10% of cancers. So if you feel something, don't go get your mammogram and go, I'm not going to tell them because I want to see if they see it. If you're like, oh, I feel something here, or oh, I've noticed nipple discharge, or oh, this part of my breast looks a little indented, make sure you tell somebody so they can take extra pictures there, because you're still your best advocate. The earliest cancer, the non-invasive cancer, the ductal carcinoma in situ, the cancer that has a 98 to 99% survival, is usually best seen on a mammogram, not well seen, if even seen, on an ultrasound or MRI. So although they're not perfect, they're still the best we have. There's so much research going on, A, to make them better, like with 3D mammograms, and B, to replace them with something even better. Be great if you don't have to come in and get squished. But you know what? They squish because they care. They have to. The more you squeeze something, the better you see. And so again, it's sort of a self-fulfilling prophecy. If you know you have small, tender breasts and you're like, you know what, I'm going to be in compression quickly and then it's going to be over. Yes, occasionally people get bruised. Yes, occasionally people are sore for a day or two. You can take some Advil or Tylenol or even use an ice pack afterwards if you know that you're often tender after your mammogram, but they need to see that muscle stripe. They need to get up into your armpit. And the more compression, the more the tissue's flattened out, the better they can see. And honestly, the 3D mammogram's compression is less than the old-fashioned mammogram, because since they're taking many little thin slices through the breast, they don't have to squeeze as hard. So who should get a mammogram? If you're at average risk, no family history, you should start at 40. There's lots of noise and controversy out there, but breast cancer is starting to occur at younger and younger ages. I see many women under the age of 40 with breast cancer. So I don't know why we would wait till we are 50. If you're at high risk, if you've got a family history, if you've been told you're at high risk for another reason, ask your doctor when you should start. For a family history, we usually say 10 years younger than the youngest person in your family had breast cancer. So if your mom had breast cancer at 45, you should start at 35. If she had breast cancer at 42, you start at 32, but we normally don't start mammograms under the age of 30, but we would consider ultrasounds and we would consider MRIs. Again, there's a whole debate. Do we do it every year? Do we do it every other year? Well, if you're at low risk, every other year is fine, but you can't really remember. Was that 1 year or 2 years? And then before you know it, it's 3 years. So like anything, just doing it every year seems easier. I laugh because some of the gynecologists follow you get a pap smear every 3 years, and I'm a doctor and I'm like, was that 2 years ago or 3 years ago? You're going to have to look it up. I can't remember. And then you continue mammograms until you are no longer well. So the idea is a mammogram is going to find something maybe 5 years or 3 years before it can be felt. So if you're otherwise healthy, I don't care if you're 80. If your mom lived till she was 95 and you're still driving everywhere you want to go and the doctors aren't concerned about major medical issues, you should still probably be getting your mammogram, because if we find something small, you can have a small outpatient intervention. Could be surgery, it could be putting primary pills, but it's a lot easier than waiting till it's big and more difficult. And then yes, if your breasts are dense, which means they look white on a mammogram, bad things are white on a mammogram, white on a white background is tough to see. That's why we add an ultrasound. So again, mammograms save lives. Mammogram has reduced breast cancer mortality in the US by nearly a third since 1990 when we started getting high quality machines in. So none of these are a good reason. I'll put a little commercial. I'm too busy. No, you're not. You're avoiding. We have evening hours. We have weekend hours. Somebody can watch the kids, so you can come in on a Saturday morning, or you can go while the kids are in school. I'm anxious. Well, you know what? We're all anxious, but if you want, they will read it while you're there, so you don't have to wait for your report to come out. Things have been a little in flux with COVID, but they really are trying to continue with that. And finally, you know, I don't have money or my friend doesn't have money. We have grants, not a ton. You have to prove you're in need. We're always happy to take donations and we're always raising funds for it. But we want our women who do not have financial means to get a mammogram to be able to overcome that barrier, because that's how much we believe in it here. And we've been very fortunate to get great grant funding to help us help underserved women get the mammograms and additional services they need. So thank you. So if you look at all of this, breasts come in many sizes and shapes. It'll make your head spin when you try to sort through the fact and fiction. So I always say, ask a trusted healthcare provider. It doesn't even have to be your breast specialist, your gynecologist, your internist, and they know lots of that as well. Looking at the mammogram will scare you. Like if you're looking over at the screen, I always ask our radiologist, well, why is that white spot okay and the other one isn't? And they look at me and go, because it is. And I'm like, yep, that's why you did a fellowship. And again, small, early makes things very, very treatable. So hopefully I got through a lot of what you want to know. I want to leave Barb Carr a little bit of time to answer and talk about our questions. So we'll get to them in a minute, but I'm first going to stop my slide set and hand it over to Barb. Barb Carr is our service line director for both women's health as well as the pediatric lines. For many of you hopefully know her from the Women's and Babies campaign as we attempt to raise money for a new nursery and other services for the women's service line. I'll put that commercial in for you too, Barb. And she really wants to explain some of our services and how you access them. So let's see, I'm going to stop sharing. And there you go.
Can you hear me? Can you see me?
Yes.
Okay, great. Let me just do, and can you see my slide? Yes?
Not yet.
Not yet. Okay, hold on. Little technology here, share screen. Why is it not coming up? Not seeing it yet?
No, I just see you. I see you and I hear my dog. It's all good.
I'm sorry, let me just try this one more time then. Because it's here.
I see it in the reflection.
Yeah, see, I really am doing it.
It is
true.
true.
My screen, and I see that there. I'm sorry, folks, it worked before, but.
It might be displaying in the other monitor. Is there?
Well, I have two monitors. The one where you see me is one, and the booking your mammo is the other.
But that's why he's saying you've got it on the wrong monitor. It has to be on the one where we're looking at you. It can't be on your other screen.
You see that now? No?
Try clicking share screen again and see if it'll let you select it again.
All right.
Thank you, Anthony.
Oh, of course. Thank you.
It's weird because it's showing that it's selected. It's outlined and everything. And you clicked off, right?
We wouldn't see you if I didn't click off.
Up now.
Oh, yep, that's it.
You see it now?
Yes.
Okay. So hi, everyone. I'm Barbara, as Dr. Pass mentioned, and I love that presentation. I always learn something. So I'm just going to take you through for 2 minutes and just give you an idea of where our locations are, and really that we really make this very, very easy for you. We want it to be as easy as possible. We have 4 different locations: Stamford, Darien, Wilton, and Greenwich. To make your appointment, you can just call the 276 pink number. We also, if you prefer not to get on the phone, you can do a real-time chat on our website, and that's between, I believe, 8 and 5:30 every day. And we also take online appointments. So I will just quickly take you through how that works. We have, when you call, we do have some wait times, but they're minimal. We really want to make this as easy for you as possible. If you go on and you want to do a live chat, you could see here, this is what would happen. You would put in your information here. You would click, how best to get in contact with you, that you want to make a breast center appointment. You'd submit that. And then somebody would get back to you between 8 and 5:30 during the day. You can also request an appointment by filling out the book your screening now form. And that's the form that you see here that people can access very easily. You fill that out. You indicate the way you want to be reached, whether it's email or phone, and then you hit the request an appointment and somebody will call you. You can even tell us which location you want to try and make your appointment in, and we will do everything we can to accommodate that. And we get back to people within 24 business hours. So again, we try to meet you where you are and help you in whatever way possible. And I just want to say a few words about just overall the women's health services that we have. Not only do we have the breast center, which I'm just going to do a little bragging now. We're NAPVC accredited, which is a national accreditation. That's difficult to get and difficult to maintain, and we've had it. We were the first hospital actually in the world to get this accreditation, and we've maintained it for all of these years now, and so we're very proud of that. We also, as Dr. Pess was mentioning about the 3D mammography, we have the 3D at all of our locations, and you can get your results same day at your appointment. There's no waiting. There's no 3 days later. You can get it same day if it's during our regular business hours. Since we've been with COVID, we had to adjust that sometimes just to make sure we kept people flowing in and out of the center. But that's not an issue for us so much anymore. But we'll give you a call the same day and let you know if you decide that you prefer to leave. Dr. Pass also mentioned about our fellowship-trained breast radiologists and breast surgeons. Not all centers have physicians who are fellowship-trained. That adds another layer of education, a much greater layer, and we're very, very proud that we have that to specialize in breast care. We also have something unique here that many centers do not offer, and that is at every screening mammogram, we do a risk assessment, and we will tell you whether or not you might be at high risk for developing breast cancer or during the course of your life. And if that's the case, you would get a phone call from our high-risk coordinator who would tell you about a program we have, ask you if you'd like to be a part of it, and you could see a breast specialist to determine what you might be able to do to mitigate that risk. And we have dedicated breast and lay navigators to help you through this whole process. And if you need additional imaging, we have that also on site, especially in the Stamford Tully location. We have obstetrics and maternity services. So for any of you who are in childbearing age, or if you have granddaughters or daughters and you want to pass the word on, we have amazing facilities and many, many different types of care that we provide. I'm just going to highlight a couple of them. We specialize in women who are at high risk. We have lots of services for women who have complications or have complicated pregnancies. We also, and this is another thing that's unique to us, we have an OBGYN hospitalist program. So that's an OBGYN that's in residence on our labor and delivery floor 24/7 to assist with any emergency or to assist a physician and to assist our residents. So we have, what that really means is that this is an extra layer of care for our women. And then lastly, we have the Women's Specialty Center, which is opened a couple of years ago. And this is a center right here on our main campus. And it incorporates, I just have a few of the things, I think I've only listed 5 bullets, but we've got many, many different things in that center that are particular to women's health. Things such as pelvic floor physical therapy, That's something that can affect women after they give birth. It affects a woman at any time in her life. And so we offer this specific type of therapy to women in this center. We have GYN for adolescents, which sometimes is hard to find. And then, as I mentioned earlier, we also have the perinatal and the high-risk specialties within that center. And that even includes fetal ultrasounds and monitoring and anything with that for a woman with any other kind of high-risk need. And we also offer genetic counseling and consultations with our double-boarded medical geneticist and her team. And lastly, we have some Yale physicians on site every day who are GYN oncology specialists. So all of that means we really hope that you will find us on the web, give us a call, come on in and see us, and we're happy to help you and to answer any questions you may have. Thank you.
All right. Thank you, Barbara. So we do. Yeah, you can stop sharing if you actually. You know what? You could keep it up because it does have the number.
It's so pretty, right? The pink.
Exactly.
All right, so we do have a couple of questions. The first question is, and I just want to let everybody know that all the questions will be anonymous. So if you do have something you want to ask Dr. Pass, please feel free to. They will be anonymous. Can calcifications in the breast turn cancerous? At what age should a woman cease having mammograms? I will be 80, and I wonder if there is a standard.
Okay, so that looks like that's two questions.
Yep.
Calcifications do not cause breast cancer. They don't necessarily turn into breast cancer. They're a marker that something is going on in your breast. Most calcifications are not cancerous. The reasons that our breast radiologists do fellowships is because it takes a fine eye to differentiate between which calcifications are worrisome and which ones aren't. So it's not the presence or absence, but how many do you have? Are they increasing in number? What's the size and shape of each calcium spot? And really, what's the pattern that raises or lowers the radiologist's level of suspicion? If they're concerned, they will recommend a biopsy. And again, the vast majority of the time, they will not turn out to be cancer, but we never want to miss a cancer, which is why the biopsy is done. So calcifications are a marker of cancer. They don't cause cancer and they don't turn into cancer. How old should you be when you stop getting mammograms is a tough question, but if you're in relatively good health and your expected life is at least 5 more years, you should still be getting mammograms. So if you're in good health and you're going around and you're doing everything you do, we've seen breast cancer, your risk of breast cancer continues to go up the older you get. Some people think after 80, it may go down a little, but you're at your highest risk you're going to be in your life. I would rather have you get a mammogram and find something very small that is very easy to treat as an outpatient, maintains your independence and quality of life, than have you continue to be well, but been told, oh, over 70, you don't need a mammogram anymore. And then you show up with something the size of a hard-boiled egg, and then it can be more difficult to treat. In the US, we used to say over 70, you shouldn't get a mammogram. In England, where they ration healthcare more than us, they made the age go up to 74. And they actually, the healthcare service there said once you're 75 or older, your provider will no longer recommend it, but if you ask for it, you're entitled to it. So I found it interesting that a place that rationed healthcare was more progressive than we are. And then we switched our recommendation to, as long as your life expectancy is 5 years, get it.
Thank you. The next question asks, I have been told if you have dense breasts, you are at higher risk of getting breast cancer. Is that true, or is it because it's harder to detect on an MRI?
Breast density is an independent risk factor for getting breast cancer. You can't control the density of your breast, so it's one of those risk factors that is unfortunate. Some of the theory is breast density is somewhat linked to estrogen, or how your breast tissue processes estrogen, or how sensitive your breasts are to estrogen. I have women who are 80 and still have dense breasts, so that's partially how they're made and partially how they process it. We do know, like, women who've had breast cancer and end up on anti-estrogen pills, often their density will improve, or after menopause, density will improve. But density is a marker of increased sensitivity to estrogens, which is a risk factor for breast cancer. Women with dense breasts, we recommend an ultrasound because it's harder on a mammogram to see the cancer if you have dense breasts. We always get into a problem with ultrasounds because Connecticut passed a law saying your insurance company has to cover a screening ultrasound if you have dense breasts, but they don't recognize a ultrasound as a screening or preventative study. So your ultrasound is subject to your copays and deductibles. So depending on where you are in your deductible, they may not cover $1 of your ultrasound. And depending on what your copay is, they won't cover all of it. You're entitled to get it, but the insurance coverage varies. There actually is a petition in the state legislature now to say if we're mandating insurance companies have to cover it and we view it as a screening test, we should mandate that it's covered like mammograms, but it hasn't passed.
Thank you. And that you answered another question, because somebody else asked about Medicare covering the ultrasound automatically. So thank you.
Sure.
The next question asks, if the pain of a mammogram is just too much, I feel like I'm going to faint or vomit. It hurts so much. I stopped going. I just couldn't deal with the pain. Can I just get an ultrasound?
So an ultrasound sees things differently. It's good for finding little lumps. It's good for telling us, is a lump full of fluid, which is a cyst? Is a lump full of a fluid with little walls inside like a honeycomb, which we call a complex cyst, or is it solid, in which case it's an actual mass? So that's where an ultrasound shines. That's why OBs do ultrasounds, because a baby's floating in a little pool of fluid and we can see everything really well. But an ultrasound will miss the earliest cancer. For people who say, look, a mammogram's just exquisitely painful, I have a couple of recommendations. One is to make sure you talk to the technologist. The other is if you've avoided them and you haven't tried a 3D, usually that's less compression. And I do have some women, if their stomach's tolerated and it's okay with their other medications, pre-medicate with an anti-inflammatory drug. So Motrin, Advil, Aleve, any of those, just to see if having a little medication on board really helps. And then actually icing afterwards if you know that you're prone to bruising because of it. So I wish I could tell you that we have something better than a mammogram, but we don't. I do encourage people, even though they've had a bad experience, to maybe try it again. And every once in a while, your primary care provider will say something's better than nothing, but know that doing an ultrasound alone is not going to find some of the earliest cancers.
Thank you. So the next question asks, aspirating a cyst used to be done simply with a syringe and a needle and was completely painless. Now it's done with a stapler, almost gun-like device that causes a big bruise. Is that really a better way to treat a cyst? Can I request a simple need aspiration?
So a cyst, again, we'll go through our terms, is a little lump filled with fluid. They still aspirate those under ultrasound. They still use a simple needle with a syringe. But if the cyst is not just water filled, sometimes cysts get old and get full of older fluid, like your clear fluid turns to snot. It's not going to come out of a needle about the size that we draw our blood with. Or more often they use that stapler-like device, so an automated biopsy device, when they want a little chunk of tissue because they're not sure it's a cyst, it looks more solid, or actually what you're misterming your lump a cyst when it was actually a lump that was a mass that was solid and they took a piece of it. And yes, just like when you draw blood, you can get a bruise from your blood draw, and that's why they hold pressure. Yep, when they take an actual little piece of tissue, it's not unusual to get a little bruising, and that will go away. But we do the biopsy because we never want to miss something. So if the radiologist is concerned and they think they need to take a little piece of tissue, that automated biopsy device actually gives the pathologist a much better sample that lets them tell us, is it something we don't have to worry about and you're going to go home and be done? Or is it something that needs more intervention? You have to come see me and we have to talk about next steps.
Thank you. The next question asks, how important is hormone therapy after lumpectomy and radiation in early stage 1 estrogen positive cancer in a 68-year-old?
Okay, disclaimer, I cannot give any specific medical advice because there's so many details missing in that, because there's a whole range of estrogen positivity. There's a whole bunch of different sizes in stage 1. But I will tell you that for invasive breast cancer, which is stage 1, the reason they give hormone therapy, which is actually anti-estrogen therapy, is not just to treat the breast, but once a cancer is invasive, it's at risk that it could have spread elsewhere. And while there might just be 1 or 2 cells floating around, they want to starve it of estrogen so it can't grow and can't implant itself somewhere else. Usually the medical oncologist who's prescribing this treatment can give you much better numbers saying, here's what I think the degree of benefit is, so we can have a shared discussion about, is it worth tolerating the side effects? Some women take it and have no side effects. Some women take it and have every side effect listed and then a few more. And so again, that's where a good balanced discussion with your medical oncologist. There's more than one type of hormone therapy. And for the type of hormone therapy, there's even more than one drug. And the best analysis I can say is working with them to, if the first one, you're having side effects that are impacting your quality of life, seeing if changing to another one works, and also asking them based on quality of life, is it worth putting up with it? I will also say 68 is not old. So again, if the life insurance tables say if you live to 72, you've got a very good chance of living to 90. And so 68 is not that old.
Thank you. The next question asks, what's the latest treatment for non-invasive intraductal carcinoma in situ?
You're doing great with those big words. So
I'm trying.
That's a synonym for ductal carcinoma in situ, or DCIS. We're trying to get smarter. We're trying to de-escalate care. We have every treatment option based on how big is the spot? How sure are we there's no invasive cancer in there? Was it been well sampled? How old is the person? What's the grade? What are their aversion to risk versus aversion to side effects, and how do we balance that risk-benefit ratio? There are clinical trials looking at active surveillance, do nothing but watch. There are clinical trials saying, let's put you on anti-estrogen medication. There's people who do surgery, get specific tests that look at the genes and say, is there a benefit for radiation? There are people who get surgery plus radiation. Most people don't get radiation alone. And there are some people who get surgery, radiation, and anti-estrogen medicine. So DCIS is not just one disease. There's many different grades, many different sizes, and many different levels of aggressiveness. So we don't have a latest treatment. We just have a larger menu of treatment options now.
Thank you. So we have one final question, and the question asks, how long does it take cancer to develop in your breast before it is seen in a mammogram?
We say, and again, it sounds abhorrent, for a cancer to show up in a mammogram takes at least 5 years. And it's really discouraging to a woman who says, you know what, I've gone every year, and how the heck did I get it? And what do you mean it wasn't there last year and now it's 1 centimeter? It had to have been there. And the problem is our level of resolution. We know things hide on a mammogram. You know, you drop that pee in your bouncy ball bin, you're never going to find that pee lost in the bin of big balls. So hiding in your lobules and tubules and glands and supporting structure, little things can hide. And that's why they pull and they tug and they squeeze and they ultrasound and they even 3D multi-slice and biopsy, because we never want to miss a cancer. But still our most sensitive test. says that it's at least 3 to 5 years before it gets big enough that we can see it on a mammogram. And that's good, because when I first started, we were like 7 to 5. And now with the 3D tomosynthesis, we're like 5, maybe as soon as 3 years. And that's not to say I'm doomed if it's going to be there that long anyways. It's more to say, it's okay. If you missed your mammogram due to COVID, you're not doomed. And it doesn't mean like we all do when we diet. Well, I already had a cookie, so now I might as well eat the whole carton of ice cream because the day's gone anyways. No, if you missed your mammogram, it's not too late. It's just time to get back on it, and let's get your mammogram and let's start doing it again. So the flip side is, if it takes 3 years to develop, it doesn't mean you do it every 3 years, because it may be the next year's mammogram, not the mammogram in 3 years that finds it. So hopefully that makes sense.
Thank you. Dr. Pass, Barbara, thank you so much for spending your evening with us and the great work that you're doing at Stamford Health. We really appreciate you spending your evening with us and talking to our community.
Our pleasure.
Thank you. New Canaan, thank you. New Canaan community, thank you for spending your evening with us as well. And I wish everybody a wonderful night.